Hello and welcome to Postpartum Wellness Initiative for South Jersey's Maternal Mental Health interview series, where we chat with local professionals working in the perinatal mental health field. Today, I'm joined by Gina Abbondante. Gina Abbondante is a licensed clinical social worker in South Jersey. She is the owner and clinical director of Change of Mind Counseling Services, a multi-specialty group practice. Gina's specialty and passion is treating anxiety disorders and OCD, particularly in the perinatal population. She is trained in exposure and response prevention, acceptance and commitment therapy, inference-based therapy, and mindfulness-based stress reduction, as well as equine-assisted psychotherapy. In addition to treating clients, Gina also provides clinical supervision for LSWs and LACs looking to obtain clinical licensure and consultation for training in tough cases. In recent years, Gina has begun to provide trainings for other clinicians interested in learning how to treat anxiety disorders and OCD in the perinatal and maternal mental health community. She was an early adopter of inference-based CBT for OCD in the United States and was trained directly by the co-founder, Fred Aradama. Gina is also one of the co-founders of OCD Lived Experience Collective and OCD Training School. So Gina has an awesome background, and I'm really looking forward to this conversation. Gina, I know we were kind of talking about maybe talking a little bit about what perinatal OCD is, and then a little bit about what it is not.
Yeah.
And then maybe some of those common treatments that somebody might be looking at if if they're going to counseling. So tell me a little bit about perinatal OCD. You're the expert.
Sure. Absolutely. So I think it's important to first say that OCD of any kind is the most stigmatized and also most widely misdiagnosed mental health condition that is out there, which seems wild. But I think there's this common misconception that says, I can't possibly have OCD unless I'm repetitively washing my hands, or I can't possibly have OCD unless I'm checking the locks or checking the light switch over and over again. And I think that's one of the biggest reasons why so many folks go misdiagnosed for so long, is because we don't really have an accurate picture of what OCD is. So perinatal OCD is OCD that occurs during the perinatal period, and that perinatal period is during pregnancy and up to a year postpartum. It really is not its own diagnosis or its own thing. It's really OCD that occurs during that period of time. For most people, OCD occurs, if it's going to occur, it's going to occur somewhere in early adolescence. But there's also a large percentage of people, myself included, who have more of a rapid acute onset that happens in adulthood. So that's kind of what we're looking at when we look at perinatal OCD. It's OCD symptoms that occur during that perinatal period. And when we look at OCD, we're looking for obsession, so obsessional thoughts that scare us, and compulsive actions that we do to try to neutralize those obsessive thoughts that we have, or neutralize the anxiety and distress that comes up from those intrusive thoughts or obsessive thoughts. We have to have both. So it's not just one, it's not just the other. So it's not just, I have obsessive thoughts that scare me, or I just have compulsive actions. You have to have both of them to meet criteria for the diagnosis. And those thoughts that people have, they really range. There's a whole ton of different themes and subtypes within the OCD community. And it's not, contamination is one piece of it. I think that's what we really commonly see, or what we think of when we think of OCD. We think of contamination, we think of fear of germs, we think fear of being dirty. And that's just one piece. There's existential OCD, there's harm OCD, where we are afraid that either harm is going to come to our family, or harm is going to come to us, or we are going to harm our family, or we're going to hurt ourselves. Existential OCD is when we have thoughts about is this world real? Am I stuck in a dream? How do I know? How do I know if things are real? There's scrupulosity, there's morality, there's just right OCD. There's so many themes and subtypes. It's really, the sky is the limit, honestly. So it's important to remember, a lot of times we think that it's just going to be centered around that fear of getting dirty or fear of getting sick, fear of germs, that sort of thing. But it's not. It's so wide. And I think that's another reason why it tends to get misdiagnosed, is because it's just such a big, wide topic of having OCD, and that so many people really don't know what they're seeing when they're looking at it.
Right, right. Yeah. And even as a clinician, I'm wondering how many clinicians may not even know what they're looking at when someone's talking about, like, some of the things that you had just said were even a surprise to me. And I feel like I know a little bit more about OCD or a lot of it. So it's just so interesting to hear. Now, I wonder too, my other question that just popped into my head, I guess, is when someone, I guess this is like an important emphasis or something to point out, I guess, if someone is diagnosed in the perinatal period, so either pregnancy or postpartum, it doesn't have to revolve around their baby or their pregnancy, correct? It could be anything. So I feel like that might be something that someone thinks, oh, it's only OCD, it's only perinatal OCD. If I'm thinking like that thought is about my baby.
Yeah, absolutely. So, I mean, I think it's a pretty common thing, and there is a line between what's normal worry and what's normal concern about, my pregnancy being healthy or my child being okay. But yeah, no, the obsessions don't have to just focus on the baby. It can be totally outside things, and just the baby is present for that experience with the parent.
Right. That makes sense. Now, if you have somebody or if you had advice for someone that might be either listening to this or you have a client or someone that calls you at your practice and says, I think that I may be experiencing some symptoms of OCD, also keeping in mind that that person may have a misconception about what it is anyway, because I feel like most people do. What is the next step that you would say either for them or like something that you would do for them in in your practice?
Yeah. So I think we're in the age of Google. So a lot of people come to me having Googled their thoughts, which is a compulsion. So I really try to encourage people to not do that. But the first thing that I do is I try to impress upon them that it's going to be okay. That I think a lot of times people come to therapy because they are so terrified of what their brain is feeding them. They're so terrified of these thoughts. They're so terrified of what it means about them. They're so terrified of everything that's happening in this whole experience that I first just try to get them to slow down and just let them know, listen, this is going to be okay. This is something that is common. It is treatable. It is incredibly distressing and it's awful. And I've been there and I hear you. And this is also going to be okay. Purists of OCD treatment would tell me that I'm providing reassurance, but I think that there is, in this particular time frame, and really for anyone experiencing OCD, we need some assurance that we're going to be okay, that we're not completely losing our minds. And then if someone keeps coming back for that and keeps looking for that reassurance, that's where we have to, put the brakes on. But I think in those early stages, some people really need assurance that it's going to be okay, that you're not in trouble, nothing awful is going to happen, your brain is okay, you're not totally losing it. But I really think that in the early stages we need it. So that's really the first place that I start. And then from there, I start providing some psychoeducation to clients so that they understand what's happening. They understand the process of how OCD works, how, it's really it's feeding itself, and that the treatment that we are going to do involves no compulsions or dropping the compulsions and learning how to stop engaging in that OCD process. Because OCD is not something that happens to us. It's something that we engage in. It's a process that we engage in. So if we can learn how to step out of that process through a variety of different things. So some of it's behavioral, a lot of it's cognitive. But if we can learn how to kind of remove ourselves from that process, then we can develop a better sense of clarity and control and autonomy over what that experience is like for us.
Sounds like a lot of work, but it's good work to go from being stuck in the tornado, like that almost sounds like that kind of like cycle, those thought cycles, to being able to kind of like look down on it or feel like you're not, necessarily swept up in it.
Yeah, it is really hard. I mean, I won't sugarcoat it for clients. Because I have OCD myself, and I am very open with my journey, and I tell them that it was the hardest thing I've ever had to do in my life, bar none, So I validate that this is going to be really hard. It's going to be really scary. And there's also light on the other side of that. And then we talk about what treatments would look like and how we're going to address treatment and how we're going to move forward and kind of give them a more realistic picture of what this is going to look like for them.
Mm-hmm. Do you find that a lot of clients are, when you kind of get to that point of like setting the expectations, are they kind of willing to or able to kind of put in that work at that point once they realize it's probably a breath of relief to be, to be able to realize that there's something that can be done about it, just like a health problem, right? Like it's nice to know that there's treatment available and that you can, do something about it.
Yeah, definitely. I think I kind of get like people are sort of like 50-50. So I think people always come to treatment because they are miserable. They want to do something. They want to be able to start to feel better. They want to get better, they want to get back to enjoying their life. And then when I start to explain to them what treatment's going to look like, then I start to get some people that are maybe a little bit afraid to let go of some of their doubts and some of their fears. Maybe some people that are afraid to step into treatment because of what that might mean. Yeah, sometimes it can be a little bit of a tricky place. Like there's that fear of continuing and what that would mean about them, but there's also a fear of letting go and being able to really immerse themselves in the treatment.
That makes sense. That makes a lot of sense. And in terms of treatment, I know kind of talked a little bit about, and forgive me because I'm totally not very aware of multiple treatments or anything, or some of the verbiage, but you'd mentioned something about reassurance versus assurance. Are there typical treatments or like major ones that are found to be the most effective, or are there more that have been developed recently? You mentioned OCD purists. So what are some of the options out there if somebody is coming to your practice or any practice that maybe would be good, especially for the perinatal population?
Yeah, for sure. So if anyone hops onto Google and they look at treatment for OCD, the first thing that's going to pop up right now is exposure and response prevention. And exposure and response prevention, it tackles, number one, exposing people to their thoughts, their feared outcomes, exposing them to those experiences, and also teaching people how to not engage in the behavioral responses or the response prevention, the responses that we do to the thoughts that we have. So that's the first one that everyone is going to see, and it's the one that's probably the most well known. I am trained in ERP. I will say I take a pretty different approach to it, though, because research shows that there is no benefit to doing extreme exposures, and some therapists will have their clients do really extreme and above and beyond exposures to help what's called help your brain habituate to the fear or habituate to the response. It borders on torture. And I never really felt like that was the right path for me as a therapist. So I lean more into what are lived in experiences. So people that are afraid of their thoughts you can't escape your thoughts. So you're going to have constant exposure to the things that you're afraid of all the time. So we need to lead into more of the response prevention piece versus going out and doing extreme exposures. So I focus more on let's do some more of just the things that happen organically. Let's call those exposures, things that are going to trigger you anyway. And let's focus on that behavioral portion of it. And then in more recent years, probably the last, I guess, maybe 2 years or so, I started delving into the world of inference-based cognitive behavioral therapy for OCD. And that comes from a totally different angle. So if you're looking at CBT, right? So ERP would be little c, big B. So it's really heavy on the behavioral portion of it. not a whole lot of emphasis on the cognitive portion of it. Whereas inference-based CBT is heavy on the C. So it's big C, little b. So you're really going for that cognitive aspect. You're looking at the sort of mental gymnastics that people with OCD are doing, that's helping the OCD process to proliferate and continue and keep going. So we're helping people to look at what are those faulty inferences that you're making about the doubts that you're having? What is the logic that your OCD has, that it's pulling in like a magpie, all these little pieces of things, that little pieces of evidence that you've been gathering your whole life to justify this doubt that comes up? And where are we using possibility as evidence here versus relying on our senses, our five senses and common sense to tell us what is happening in the real moment and what we can trust and rely on. So those are sort of like the two biggest ones. There's also some other ones, like there's metacognitive therapy, which I think is very useful to help people understand what their fusion beliefs are. Those are things like thought fusion and thought action fusion, which says that thought action fusion is just the presence of having a thought is just as bad as having acted upon that thought.
Oh, wow.
And then thought fusion is having a thought about having a thought in the future and reacting to that. So there's all these fusion beliefs that come up that I think is really helpful for people to understand. And then there's acceptance and commitment therapy, which is a pretty popular one in the world of OCD. And there's mindfulness-based cognitive behavioral therapy for OCD. So there's a lot of different options. And I think it's important for therapists to have a variety of tools in their toolbox, depending on who's sitting in front of them,
Right.
I'm not, when I say OCD purists, it's a lot of therapists that really just have one primary modality and they're like, nope, this is the one that works. And I don't think we can rely on that, because every person is different. Everyone has a different learning style. Everyone has different personalities. And we need to have a ton of different tools in our toolbox to be able to tailor treatment for whoever is sitting right in front of us.
Right, exactly. And then even as far as different histories where somebody might have a harder time with something that involves just getting big B and going out and do it, and getting that exposure, like that might cause a whole trigger response domino effect that they might not be ready for, or which totally makes sense, but it might be appropriate for some people. It makes sense. And it's the same as like, just to compare, I guess, but like there's different medical treatments, and it doesn't invalidate one when there's a new one out there. It just means that there's another option for somebody that has this other diagnosis or this history or what have you. And it's good that there's more and more more and more common for different varieties of people. For sure. Is there, have you noticed with the perinatal population, just to kind of bring it back around to pregnant and postpartum people, are there any specific challenges that you've kind of noticed with that population versus just the general, or things that you can kind of see that might be different with them?
I think things that I think a couple things that sort of complicate it with the perinatal population is, number one, that sense of over responsibility, because they do have a small humans that they have to keep alive. I think that definitely complicates things, because it's not as if they can let go of the responsibilities that they need to do to take care of their baby. So I think that is a complicating factor. I think lack of sleep and lack of support is a huge complicating factor in OCD recovery, because if you're not sleeping, then your amygdala is going to be more reactive and more sensitive, and then that's going to make the anxiety worse, and it's going to make it easier to sort of slip into your imagination of OCD, and then it's going to make them sleep worse. So it's just this like snake eating its tail cycle of not getting enough sleep and not having enough support. And then, of course, there's always the societal standards of what we believe a perfect parent should be and what a perfect mother should be. I think that sort of complicates things. And then we also live in a world where keeping parents afraid is big business. So if you keep a parent afraid that they can't trust their senses on knowing how they can take care of their baby, then they can sell another gadget. So I think that sort of, it complicates things as well. And I think all of those things sort of cluster together to create, some big challenges for working with the perinatal population.
For sure. And then those are all such good points. And it's interesting because it's all a lot of things that we see just with any diagnosis. All those things that you brought up, I'm sure, I mean, anytime you have someone with anxiety or someone with depression or anything like that, those are all things that pop up with, all of those clients. Another question that kind of just popped into my head as we're talking also is, and actually this was a client recently had this question and I wasn't really sure how to answer. So maybe I'll call them after we're done with this. But what are some ways? So I know that perinatal OCD specifically is, if it develops pregnancy postpartum. If someone has been diagnosed with OCD before they were pregnant, what are some of the is there anything that they should look out for, things that may trigger symptoms coming back or some risk that they may have? Because I mean, all the things that we talked about are true for everyone, the lack of sleep and these things. Is there something that maybe those clients can be looking out for as they're preparing to give birth or maybe in that postpartum period?
Yeah, definitely. So it's a little bit of a tricky question because the more attention that we pay to the OCD, the louder it is going to get regardless. So if a client already knows they have a history of OCD in the past, and they're concerned about it, getting louder or coming back, so to speak, it's already back. So if you're worrying about it coming back, then that seed of doubt has already been planted, and then they're watching it and they're going to be looking for symptoms. So it's sort of already there. The relapse has happened. So what I often will tell people is, I'm not going to be like, just don't pay attention to it. What I will tell my clients is, let's come up with a plan for if this happens, what's our plan of attack for how we're going to deal with this, right? What are the things that we have done in the past? So we're basically just going to beef up the skills that we have already done through their treatment. And with OCD, a lot of it's such an internally focused thing. That's the only way I can describe it. Such a scientific word, but it's such an internally focused thing that part of the treatment is helping to push that sense of awareness outside of our own body, reconnecting back to the world that's around us. So I will often work on clients saying, are you checking? Are you watching? Are you scanning for body symptoms? Because those are all compulsions. So if you're already doing the compulsions, OCD is back. We don't have to worry about it coming back and sneaking up on you or whatever.
It's already
here.
Up on you.
So again, and I also, remind clients, OCD is not something that happens to us. It's not something that jumps up and, bites our leg in the middle of the night. It's something that we engage into. It's that process that we're engaging into. So we want to be aware that if we're doing that, if we're engaging in that process, it's already back. It's already here. So let's go back to doing our response prevention. Let's go back to doing the skills that worked in the past, beef them up, come up for a plan for when stress does get higher, because there are certainly, times in our life when OCD is going to be quiet and then it's going to get louder again. And times of stress or change are going to be some of those really big times. So let's make a plan for how we're going to handle that when it happens.
Almost like a way to keep the fuel low, or to not feed the little critter to get bigger. For metaphors, I love metaphors. And I feel like that can be true of a lot of different things too. And it's very empowering to hear something like it doesn't happen to you, because I think a lot of times just clients and general, that's kind of how they picture a diagnosis at all. Is it something happening to them versus something that they can, engage in or not engage in? And I mean, that's also it happens to a point, that's like an empowerment thing, I guess, too. And you have to get to a certain point in treatment to be able to see it that way anyway, I feel like. But it's very empowering, I think, to hear that. And maybe once again, someone listening to this will hear that and say, oh, this is a really nice way to think of it. That's, do I give it power or not?
Yeah. I mean, I'm big on metaphors as well. And I like to use the metaphor of a bonfire. And if you think about a bonfire, how do we feed that bonfire? We feed it by giving it wood, by putting sticks and, paper, whatever you're putting in your bonfire, right? That's what's feeding it. And that's what's making it bigger. Well, the way that we starve it, or the way that we make it get quiet and get low, is we don't feed it. So we have to remember that by not engaging in this process, then we're not feeding it, and it's going to naturally quiet down and, get down to what those little embers are at the bottom, And I'm a huge proponent in working with clients around autonomy, meaning that you have an active role in how you get better. Because I do think that there is this sense of like, oh, this is just my OCD. Like, I can't control that. I have no hand in this. That's just my anxiety. It's just something that happens. Well, not quite. There are certainly going to be times that your brain's going to be stickier than others. There might be times where you're maybe a little bit more emotionally reactive, for sure. But you have a ton of autonomy in how you get better, how your recovery looks like, whether or not you're going to go down that road and engage in the same things that made OCD loud before. We always have that choice in what we want to do with that. And I think that's it just kind of gives people that like, okay, I think I can do something with this. I have a role here. I don't have to be at the mercy of what my brain is going to give me.
Right. Exactly.
They have an option.
Yeah. And hope too, to be, something can happen down the road that's stressful, and I have the tools, or I can choose to have the tools to feel okay the next time that XYZ happens, that, or whatever it happens to be. Cause that's what therapy is all about. Right.
Absolutely.
So, and what a good note to end on. Hope, hope and autonomy, and things being able to get better. So thank you so much for chatting with me, and for shedding so much light on all this. This has been super helpful, and hopefully someone out there will be hearing this and thinking to themselves, this sounds like a good idea. I want to be able to choose to not, fuel the bonfire.
Yeah, absolutely.
So thanks again. And thank you for whoever happens to be listening also.
Yeah. Thank you for having me.
Thank you.